Okay, it's 2 o'clock in Brazil. Good afternoon. Hello, everyone, and thank you all for joining us today. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I want to welcome and thank you all. My name is Aline Serfati, and I'm here with Dr. Hilary Yeomans, who coordinates and moderates this series with me. Today, Hilary and I will be presenting a case together with our guest speakers, who are Dr. Bruno Vandenberg and Dr. Rola Marmoud. This session will focus on infection, and the speakers will present their cases, and at the end, we will have a Q&A session. If you have any questions at any time during the presentations, please put them in the chat box, and at the end, the speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, and also which is ocadmsk.com, and also on the YouTube channel of the Radiology Society of Rio de Janeiro. If you want to join the OCAD community, which I highly recommend, and see challenging cases almost every day, please consider registering on the OCAD website. The OCAD website is full of cases and videos of lectures and sessions. A quick reminder, attendees have not been given the permission to screen, record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material is illegal. And we thank you for your understanding, and with that, Hilary, you'll kick off the session.
Okay, thanks to assistance from my good friend Paolo Simoni, we have the great honor to have Bruno Vandenberg presenting in this session. He obtained his medical degree at the University of Liège in Belgium in 1986. He trained under Dr. Dennis Stoker at the Royal National Orthopaedic Hospital in London, and then moved to Belgium to complete his radiology residency in Brussels. He joined the staff in 1990 and worked with Professors Maldog and Professor Malgem in the department of the University Hospital Saint-Luc of the Catholic University of Leuven in Brussels. Along with his colleagues, he participated in development of MRI and MDCT imaging, and with an emphasis on bone marrow and cartilage imaging, and participated in development of MSK ultrasound in his department. Between 2004 and 2014, he was chairman of radiology at the University Hospital, and subsequently developed and oversaw the radiology residency program. He's enjoyed a rich, illustrious career in MSK imaging, having written more than 200 scientific articles and numerous bone chapters. His most recent article, published last week in Seminars, focuses on MRI of accelerated bone remodeling. He's had a great academic career with clinical research and teaching activities focusing exclusively on MSK imaging. That's the dream. He's recently, after 35 years, pushed the reset button to start a full-time clinical career in MSK imaging in a brand new hospital in Liège. His private life is enriched by the presence of his wife, Pierrette, who's a pathologist, his 4 children, and 7 grandchildren. Okay, Bruno, please share your screen.
Here we are. Hello, everybody. It's my pleasure. For me, the first time that I can join the OCAD community with MSK disorders, and I'm very happy to be here today. We will focus on infection. And my case is a nice case because we just have one diagnosis, but 2 different diseases. It's a young guy, he's 27, and he has no specific previous history. And he just remembered a knee problem 4 or 5 months ago. And then he presented in July 21 with a painful and swollen knee since 2 weeks. He had no fever, no systematic symptoms, just a big knee, which was not red. The imaging study started with X-rays in which we could see some subtle joint fluid or effusion in the left knee, but otherwise the radiographs were normal. And we went down to a knee MRI, and this is the coronal T1 and T2, and I will show you the sagittal images. But as you can see, the bone marrow looks normal. There is a little bit of inflammation around the knee. You've got within the muscles or within the adjacent fat, a little bit of inflammation and a little bit of fluid-like signal intensity in the articular recess. You can see that on sagittal images where you have a huge amount of, I would say, fluid, because it's very bright and homogeneous. We did not inject contrast material, intravenous injections, so we don't know how much there is of synovitis and how much there is of fluid. But my impression is that it's mostly fluid. It's not only within the joint, and as I told you, there are changes within the adjacent fat and the muscles. A bone scan was performed. It just shows you that this is a unique joint problem. So we are dealing with a rather recent knee swelling that looks like monoarthritis. And then you have a large differential diagnosis of septic or aseptic inflammatory change associated with psoriasis or inflammatory bowel disease or early rheumatoid arthritis. We could think of a metabolic problem like crystal disease, but he was fairly young to have such a problem. So the next step is definitely not imaging, but biology, and analysis of the fluid from the joint showed that this was an inflammatory fluid with an increased protein level, lower glucose level, and a white blood cell counts that was increased, but not as much as in a usual septic arthritis. All the cultures from the fluid were negative. Gram staining was negative, and all cultures were blinded, including PCR for gonorrhea. Blood tests showed important inflammation with a CRP of 113. He's got an inflammatory, moderate anemia, and increased white blood cells. Immunology, which has to be performed, was negative for the usual inflammatory arthritis that we can encounter, and by chance serology for Borrelia was positive. This is a very complex topic and I will not go into details, but there are different tests, different methodology, but they were all confirmed as being positive for Borrelia. So the diagnosis was Lyme arthritis, although the patient did not remember any tick bite in the previous time. So Lyme disease is a well-known disease in the US because it was described in the Connecticut with a large series of patients, children and adults, who presented with asymmetric painful swelling of the large knee. It was believed to be some sort of rheumatoid arthritis, but then the septic origin was described. It mostly involved the children, but also the most elderly people. It's very complex, and I will not go into details, but everything starts with a tick bite that inoculate the skin of the patient, and then local proliferation of the germs, and then dissemination, and it goes back to the skin, the central nervous system, and the joint. The history can go very fast, a few days, or very low. And this is one of the reasons why the biological diagnosis of these diseases is difficult. Dealing with MSK symptoms, it's usually part of the late disseminated episode of that disease, although this remains discussed as well. To summarize Lyme arthritis, You have to deal with a young patient. It's usually a unique or oligoarthritis of the large joint, mainly the knee, occasionally the shoulder. History of bite is not necessary. You've got inflammation in the blood and in the joint fluid. And definitely this is a treatment, diagnosis that is made at serology. So if we go back to our patient, he had elevated CRP at the beginning, and I show you the treatment history. He was treated first by 1 month of doxycycline, and CRP went down rapidly. But then when they stopped the treatment, CRP re-increased, and the patient had another episode of antibiotic treatment intravenously administered for that period of time. And then it was already getting better with this Lyme arthritis diagnosis. Unfortunately, we're now in November, and this is the initial MRI, and we're here 4 or 5 months later. The patient was going better, but the knee wasn't as good as it was before. And if you see this MR image obtained in November, you have another image, which is much more aggressive. You've got marginal erosion. As you can see, the menisci is decreasing in size. This is pannus that is destroying the cartilage, the bone, and the meniscus. On the sagittal image at that time, we use contrast enhancement. And as you can see, there is fluid, but there is marked thickening of the synovial tissue. And this is persistent synovitis in a more aggressive pattern with pannus formation. And this is well known, and I must be honest with you, I was not aware of that, but many of these patients do well after treatment. Some of these become refractory, and this is called antibiotic refractory Lyme arthritis. This occurs in about 10 to 15, 20% of the patient with Lyme arthritis. This is no more a septic arthritis. This is an inflammatory arthritis, and it is sensitive to the anti-rheumatic drugs that we use in common practice. This, according to the immunologist, this is a very interesting topic where the germs probably modify the genes from the joints, and then you have got a delayed immune reaction against the change that did occur. But this is extremely complex and remain discussed nowadays. So he received later Traxat, Salazopirin, and so on, and then the disorder progressively disappeared, and he is free of any symptom and treatment since 6 months. Last MR was obtained in May to show you the decrease in the bone marrow changes and the reactive change. There is no synovitis anymore, so the disorder is going away. So this is one diagnosis, Lyme arthritis. 2 different diseases. The first one is a septic disorder that has to be treated by specific antibiotics. Most of the patients do well. Some of these do not do well and have a more chronic pattern of knee arthritis or large joint arthritis that can be treated like rheumatoid arthritis, if I may say. Are there any suggestive imaging features for us to suggest a diagnosis of Lyme arthritis when we are encountering these patients? Basically not. The diagnosis is made by serology. But if you have a big swollen large joint in a child or in a young adult, if these patients are living in an endemic region, if you see a large amount of fluid, and it seems that at the beginning, this could be only fluid, if you have a synovitis with limited skin infiltration in comparison to the classic septic arthritis, or if you have a enlarged lymph node or muscle infiltration, according to these 2 papers, these could be excellent signs to suggest Lyme arthritis. I'm living in an endemic region, and so we have some of these patients, and this is another young guy, he was 13, 40, and you can see huge synovitis and enlarged lymph node and popliteal muscles involvement as well. This is a less unusual patient. She's 25. She also had, no, 22, sorry. She also has synovitis, had a positive serological diagnosis of borreliosis, Lyme arthritis, and she had adjacent muscle changes that could indicate, that could suggest Lyme diseases, although this is not specific either. Sarcoid arthritis could do the same. So what we should remember is just keep in mind Lyme arthritis if you're living or working in an endemic area. They usually involve 1 or 2 large joints. The diagnosis is challenging and it's not in our hands. But if MRI is performed, then you might suggest that diagnosis if you had a huge amount of fluid, enlarged nerve, or myositis. Yeah, we will discuss this a little bit later, I hope.
Thank you very much, Bruno.
I give you the, yeah.
Now it's my pleasure to introduce my dear friend, Dr. Hilary Humans. She's a professor of radiology at the Albert Einstein College of Medicine in New York, having received her bachelor's degree from MSK College, medical degree from New York College of Medicine, and completed MSK fellowship at HSS. She was faculty at Montefiore and Jacob Hospitals and works as full-time staff at Lenox Hill Radiology and Imaging Associates in New York City. She has authored more than 40 articles, reviews, known in particular for her work in food imaging. She incorporated and established the website for OCAD, a large free international MSK case sharing forum, and launched a small live OCAD meeting inspired by the online forum. The most recent OCAD live meeting took place a few weeks ago in Savannah, Georgia. Well, yes, I was there. Please, Hilary, share your screen.
Okay. Okay, so why can't I? Hold on. This is a bit of a holiday tale. We'll see why in a moment. Mine is a story of a 32-year-old female who's treated for hidradenitis suppurativa. Sorry for the horrible picture.
We can't see. I think we can't see. You're not sharing. Are you?
I'm not sharing. One
No.
second. I tried to share. Let me go back to the beginning. And I hit share screen. And I click share. Am I sharing now?
Now you're sharing.
Ah, good. Thank goodness. Okay, so I'll start my tale again. It's a holiday tale. It's the story of a 32-year-old woman treated for hidradenitis suppurativa, which is a horrible dermatologic condition. It results from hairs entrapped in the follicles with reactive inflammation and secondary bacterial infection. Mild cases are characterized by boils, which isn't bad enough. Moderate cases have abscesses, and severe cases have sinus tracts, which can result in disfiguring scars. Women, unfortunately, are more commonly affected. It's strongly associated with obesity and can be associated with many other conditions, including polycystic ovary disease, diabetes mellitus, and smoking, among others. She was treated by the dermatologist as an outpatient with Humira and ertapenem via a PICC line. Humira is a monoclonal antibody DMARD commonly used for rheumatoid arthritis, psoriatic arthritis, spondyloarthropathy, Crohn's, sarcoid, uveitis, and in 2015 it was approved in the US for use against hidradenitis. Ertapenem is a carbapenem broad-spectrum antibiotic, which is said to be active against most aerobic and anaerobic bacteria, notably not active against some forms of Enterococcus. The ertapenem was discontinued at the end of November when she was started on oral minocycline, which was prescribed to be taken twice a day. It's a holiday tale because she distinctly remembered that her low back pain started when she was trick-or-treating. For those who don't know, that's October 31st. And she suffered from worsening low back pain and leg weakness while she was still on intravenous ertapenem and when she started the oral minocycline. It should be noticed that she took minocycline once a day, although it had been prescribed twice a day. She was admitted at the beginning of December to the hospital with severe low back pain and complete inability to walk. This was her admission radiograph. She's a big girl. Unfortunately, you can see that her L5 vertebra is superimposed on the iliac bone. So it's a little hard to see whether there might be any demineralization or subtle erosions. I think I'm hallucinating some, but that may be because I saw the MRI, which was done 4 days later. Her CRP and ESR were elevated, and you can see dark T1, bright T2 marrow signal replacement in L5 with erosion of the inferior end plate, and less extensive but similar changes at the superior S1 end plate with abnormal signal in the intervening disc space. Here we have T1, fat suppressed T2, and contrast enhanced fat suppressed T1 weighted images. Well, it's a holiday tale because it was the Christmas season and biopsy was delayed, even though it was well before Christmas. You know, people were already on vacation. She was hospitalized, and in hospital, she was treated with intravenous minocycline and given pain management. But while she was waiting for the biopsy that would never happen, her pain dramatically improved. She could walk again, and she wanted to go home for the holidays. So she signed out against medical advice. The infectious disease doctors insisted on close clinical follow-up, so she was re-imaged just 4 days later as an outpatient. Her CRP remained elevated, and the MR changes are really pretty much stable, but this is less than 2 weeks after the baseline MRI. At this point, she had milder low back pain, which persisted on the next clinical follow-up at the beginning of January. But by the end of January, her pain worsened, and she had the long-awaited biopsy as an outpatient. Her CRP and ESR remained elevated, and you can see the biopsy needles in the disc space and the inferior end plate of L5. But this yielded no growth, and the pathology came back no definite evidence of osteomyelitis. So clinically, this was presumed a false negative by the ID team based on the clinical course, the persistently elevated inflammatory markers, and the abnormal imaging findings. So the ID attending had the disc biopsy material sent for bacterial DNA analysis by PCR. Drum roll, the answer is Streptophomonas maltophilia. Of course, it's a ubiquitous aerobic gram-negative bacillus closely related to the Pseudomonas species. It's an opportunistic pathogen with high morbidity and mortality in immunocompromised patients. I'll remind you that she was on Humira, and she also had a route of infection with her outpatient PICC line. It's notable that the isolate was insensitive to ertapenem. And remember, the story started that the low back pain started while she was still on outpatient IV ertapenem. It wasn't doing anything against this bug, but it was sensitive to minocycline. So how did this happen? Well, she never dosed the minocycline correctly as an outpatient. Remember, she only took 1 pill a day instead of 2 pills a day when her symptoms started and worsened. We proved the lack of compliance was proved by a residual pill count from the original prescription. And even after she was discharged and given a new prescription for minocycline, she never refilled that prescription. She did improve dramatically as an inpatient on IV minocycline, which is why she felt so wonderful and went home for Christmas. And of course, there was that long biopsy delay, more than 1.5 months, which is frankly inexcusable. So there are several teaching points. Best practice in diagnosing musculoskeletal infection involves a coordinated team approach. That goes without saying. If biopsy and culture are considered false negative, order a PCR. That was really the key to this diagnosis. Medication noncompliance can result from so many things. There could be a poor communication or language barrier. Could simply be the high price of drugs. That's a problem in the US, although she did have her minocycline. Or it may just be noncompliance. I got this case courtesy of my pill counting PCR ordering brilliant IV infectious disease Dr. Liz Jenny. And again, if you want to join us on OCAD, go to the website, click the box to sign up for the Google email group. Thank you. I'll stop sharing now. Okay, did I stop sharing?
Yes.
Okay, good. Okie dokie. Now it's my turn to introduce Dr. Aline Sarfati, who is a practicing radiologist and medical director at MedScan Lagos. She graduated with a degree in medicine from the Federal University of the State of Rio de Janeiro, a medical residency in radiology and diagnostic imaging at the Fluminense Federal University, and a PhD at the Federal University of Rio de Janeiro. She is the past president of the Radiology Society of Rio de Janeiro and also a member of the International Skeletal Society and an advisory board member at Medscape. She's authored and co-authored original research and book chapters in MSK radiology. Since 2019, she's one of the coordinators of the MSK Image Group of Rio de Janeiro, helping bring education and partnerships between Brazilian and international radiologists, such as this MSK case presentation series, which is a partnership with OCAD. She's very involved in MSK radiology education, having presented at radiologic national and international conferences. She's interested in all areas of MSK imaging with emphasis on rheumatology, infection, and diversity, equity, and inclusion in MSK radiology.
Thank you, Hillary, for the kind introduction. Can you see my screen?
Yes.
Okay. So my case is about a 70-year-old male presenting with groin and hip pain for 2 weeks. He underwent total hip arthroplasty in February 2019. And during his first visit to the hospital, laboratory findings showed elevated CRP and ESR, and his radiograph was normal. Bone scintigraphy was requested and showed increased radial tracer uptake activity in the proximal third of the femur, as well as in the acetabulum, and an inflammatory and infectious process was suggested. A few days later, this patient underwent an MRI, and on exoster images, we can see joint effusion with septations and signs of synovitis, as well as fluid outside the joint, outside the joint, and located anterolateral to the greater trochanter. Bone marrow edema, like signal intensity, was also observed at the superior and posterior aspect of the acetabulum. And we can also see hyperintense signal intensity in the internals and external obturators corresponding to mild intramuscular edema. post-contrast images, on post-contrast images, synovial thickening with peripheral enhancement was visualized. And this, on these coronal T1 and coronal star images, we can clearly depict the extension of the fluid collection along the greater trochanter and proximal femur. And we can also see that there are no signs of osteolysis around the femur component. And these sagittal images show mild capsular edema. So this patient also underwent dual energy CT, and these images showed subchondral cyst changes in the superolateral aspect of the acetabulum, and we can also see that the prosthesis is well centered and that there are no signs of loosening around the femoral component. On axial images, axial and sagittal images, we can also see an area of osteolysis in the posterior column of the acetabulum. So the patient underwent fluoroscopy guided aspiration, and the analysis of the synovial fluid showed elevated WBC, elevated synovial PMN, and synovial fluid culture was positive. So in summary, this is a 70-year-old male presenting with groin and hip pain for 2 weeks with total hip arthroplasty 1.5 years prior to his complaints. He also presented with elevated serum CRP and ESR, elevated synovial, WBC, and PMN, and a positive aspiration culture. And in accordance with the MSK criteria for PJI, a total score of 8 is suggestive of infection. And the final diagnosis was brucellosis. So brucellosis is caused by Brucella species, and humans can be infected when in contact with fluids from infected animals, such as unpasteurized milk and dairy products, undercooked meat, and skin penetration of those in contact with livestock. Osteoarticular involvement is one of the most common manifestations, particularly lumbar spondylitis. And clinical and image findings are non-specific. Regarding PJI, prosthetic joint infection, no test offers great sensibility or specificity for diagnosing PJI, and the diagnosis of PJI is based on the combination of clinical findings, laboratory evaluation of blood and synovial fluid, and intraoperative findings. The gold standard remains articular fluid aspiration and culture. And the recent study showed that almost 30% of PJI were culture negative after intraoperative sampling. And in those, NGS showed infection in 66% of the cases, which was polymicrobial in 91% of the cases. Blood tests are often negative and should not be mistaken for septic loosening before articular fluid analysis. What we see, what is important regarding when we see images, MR images, what are the MR images imaging features of infection when it comes to PJI? So synovitis and joint effusion. We can also see edema and enhancement of the synovium, extracapsular tissue, bone, and extracapsular collection, as we saw in this case, and sinus tracts to the skin surface. Bone destruction and reactive lymphadenopathy can also be seen. Diagnosis of periprosthetic hip joint infection use MRI with metal artifact reduction. What is important and what is not? So periosteal, if you see periosteal reaction, capsular edema, as we saw in this case, and intramuscular edema, this is important. Osteolysis, bone marrow edema like signal intensity, capsular thickening, and bursitis are not as important in accordance to this study published in Radiology in 2020. This is a companion case of a 31-year-old male with weight loss, low back pain, and bilateral paraparesis for 2 months. And this is on CT, we can see erosions at the end plates of L4 and L5, and on MRI, there is also end plate erosions and enhancement collection around the paravertebral collection and enhancement of the disc with sinus tract extending from one of the abscesses to the soft tissue and skin posteriorly. And this is the case of brucellosis, kindly sent to me by Dr. Sergio Viana from Brasilia. So brucellosis versus tuberculosis in the spine, what is the difference? So to make it fast, few studies have investigated that the difference between brucellosis and tuberculosis, and when it comes to imaging. And in summary, in brucellosis, vertebral collapse is rare, vertebrae are affected contiguously, and paravertebral abscesses are less extensive than in tuberculosis. Key points here are clinical and imaging findings are non-specific in brucellosis. The diagnosis of PJI is based on a combination of clinical findings, laboratory evaluation of blood and synovial fluid, and intraoperative findings. Imaging is relevant for the evaluation of the differential diagnosis of PJI, but it is not part of the 2018 PJI diagnostic criteria of the MSK. Aseptic and septic loosening can be difficult to differentiate. However, infection usually causes faster osteolysis and periosteal reaction. Inflammatory markers such as WBC count, ESR, and CRP have good sensitivity, but low specificity. I want to, before I finish, I want to thank my colleagues from Brazil and Portugal who have kindly helped me putting together this presentation. Thank you very much. And now it's me again. I will introduce Dr. Rolla. Just a second. Okay. Dr. Rolla Hussein is a musculoskeletal radiologist in Bahrain. She completed the Arab and European boards of radiology. She also completed her first fellowship in the musculoskeletal radiology at Mount Sinai Hospital in New York, and second fellowship in diagnostic intervention on musculoskeletal radiology at Vancouver General Hospital, British Columbia, Canada. She has a special interest in sports medicine and MSK intervention. Please, Rolla, take it away.
Thank you very much for the kind introduction. Hello, everybody, wherever in the world you are. And allow me to take you, first of all, I have nothing to disclose, and allow me to take you on a journey to this region of the world to talk about one of the common entities with a focus on infection. So in other words, infection with a Mediterranean flavor. So our case for today is for a 39-year-old female. She's a known case of sickle cell disease with multiple hospital admissions. She presented with fever and left leg pain. Unfortunately, I couldn't get hold of her radiographs, but these are the CT images. So as you can see from the first glance, the background of the bone is not normal. So we have heterogeneous density, sclerosis, lucency. So we're probably dealing with.
Excuse me, Rola.
Yeah.
You're, at least on my screen, the images aren't moving.
They're not?
Are they moving for anyone else?
No.
Oh,
You didn't start the presentation.
oh, let me try again.
Go on to presentation mode.
It does say on my screen, so I'll try again.
Start slide presentation.
Then go to presenter mode.
Slideshow. Go to slideshow.
Is it working now?
No, go to slideshow. Start from beginning.
It is on slideshow actually. It's weird. I mean, on my computer it is.
No, we're not seeing that.
Yeah, let's try again. Is it okay now?
No, this is just the
Oh, so maybe I can do it without slideshow.
no, I think it has to be slideshow. You go to the top bar, hit slideshow and start from beginning.
It is. Can you see? It is. I'm pressing on it.
No, or do you maybe have it open in two windows? And you're sharing the wrong window?
Yeah.
Not really. Let me try again. Sorry about that.
How many screens do you have?
Only one. That's weird.
And when you click to share your screen, Zoom
Yeah, it's only one.
multiple options. Which one are you choosing?
Let's try again. Okay, let's do this one. And now, is it working?
Yes, now it is. Thank you.
Okay, cool. All right, so shall I start from the beginning or?
Please, yes, please.
Okay, sure. So I have nothing to disclose. And again, so briefly, the history is 39-year-old female, known case of sickle cell disease with multiple hospital admissions, presenting with fever and left leg non-healing wound with discharge. Actually, that is, yeah, with discharge. Okay, cool. Okay, so as you can see from the, you can see the CT scan. Is it sharing now? Is it working?
Yes. Yes.
Awesome. So again, see the heterogeneity of the bony background. So we have areas of increased sclerosis and lucency. So we're probably dealing with osteonecrosis, which is again a common entity for sickle cell disease. However, you can also see some other findings as well. So we have the, you guessed it right, it could be a case of chronic osteomyelitis, evident by the increased cortical thickening, as well as the maybe there's a sequestrum, as you can see, the small chip of bone. There's the cloaca. Again, we have a bony defect, which is evident along the anterior medial aspect of the tibia. Now, just to complicate the matters even more, the patient underwent a surgical debridement for this area for carbuncles. But you can see on the CT scan, there's some buckling of the overlying skin associated with some soft tissue thickening. So again, this not necessarily this is a sinus tract, it can represent a fibrosis as well. So again, I mean, we're comfortable with the diagnosis of chronic osteomyelitis, but again, the patient is having symptoms of an acute disease. So when you're in doubt, your next best modality of choice is MRI. I included these scans just again to emphasize on the background of the bone. Again, we have the serpentine heterogeneous signal intensity on T1 and T2, giving the characteristic double line sign, especially evident on the T2, which is compatible with osteonecrosis. These are the axial T2. Again, there is an evidence of edema seen by high signal intensity on T2, low on T1, and that basically enhances on post-contrast images. And they're so clear on the sagittal view. So again, when you have edema in the correct clinical setting, on a background of these changes, we were thinking of acute on top of chronic osteomyelitis. And the result of the swab, as the swab was done under debridement for the overlying carbuncles, they were for Staphylococcus aureus. The patient underwent, so basically, as you can see, we have non-absorbable antibiotic beads, which were made of vancomycin and tazocin. The patient was on 21 days course of Rocephin. She responded well, and she was discharged from the hospital. This is a follow-up scan 1 year later, showing that all was good and she was symptoms-free. Good. So this patient not only had skeletal manifestations of sickle cell, she also had other additional extraskeletal manifestations. This, as you can see, this is an ultrasound of the spleen. It is small, heterogeneous. And this is a case of basically when the patient undergoes multiple episodes of infarction, it shrinks in size. Also, you can notice hepatomegaly, and this is one of the manifestations of extraskeletal hematopoiesis. The patient also had pulmonary hypertension, evident by increased diameter of the pulmonary trunk, and some other manifestations of acute chest syndrome evident by atelectasis and bilateral mosaic appearance. All right. Allow me to give you a very quick overview of sickle cell disease. It is an inherited autosomal recessive disorder. There are basically 300,000 of babies born every year. It's predominant in the sub-Saharan Africa, Caribbean, Central America, and the Mediterranean region. And in a study conducted in 2000 in Bahrain, it is found with an estimation of 5,000 cases per year. Luckily, it's decreasing by now. What happens? So just I'll give you a quick overview of the pathogenesis. So what happens is that the glutamic acid replaces the valine on beta-globin gene located on chromosome 11. This will result in sickling of the RBCs. And when they sickle, they will have a higher tendency for a turnover and breakdown, which will result in turn in hemolysis and anemia. Also, these abnormal RBCs will get stuck in places where you don't want them to. So that would result in vasculopathy and infarction. So if these infarctions took place in the brain, the patient might have a stroke. In the extremities, they can have ulcers. In the kidney, they can have a chronic kidney disease, and it could just simply be a bone pain and infection, just like in our case. Since sickle cell disease has a high morbidity and mortality, these patients usually have shorter lifespan by 25 to 30 years in comparison to the general population. The diagnosis of sickle cell disease infection is quite challenging because you're not dealing with a normal bony background. So I thought in order to facilitate a smoother and easier diagnosis, I might as well give you a quick overview of the skeletal manifestation of this disease. So rule of thumb, patient presents with emergency with a bone pain as a known case of sickle cell. You can't not include the following on your differential diagnosis list. You have bone infarction, subperiosteal hemorrhage, osteomyelitis, or actually all of the above. If I ought to group them in three major groups, we have, first of all, vaso-occlusive crisis that can be presented as bone infarction with or without subperiosteal hemorrhage, with or without infection, just like pretty much similar to our case without the hemorrhage. Or in some instances, they could be standalone infection, or in some other instances, you have chronic anemia, which will result in expansion of the medullary spaces. So speaking of which, first of all, we have osteonecrosis. It has tendency to involve the medullary cavities and the epiphysis of long bones, and it likes to involve the proximal humerus and the femur, as well as the vertebral bodies. It can also involve the ribs. As you can see, the heterogeneous appearance of these ribs with sclerosis, with areas of lucencies. And these patients can also present with chest pain and hypoventilation, in some instances, hypoxia because of the pain. They can also involve the spine, and especially it gives you the character, in severe cases, the characteristic H-shaped vertebra as it involves the midvertebral body. This is just another demonstration of H-shaped vertebra. You can also notice the generalized low signal intensity on T1, which was compatible with red bone marrow reconversion. Again, one of the entities found in this disease. It can involve, as we said earlier, the femoral heads, and it can result in avascular osteonecrosis. As you can see on the right, the radiograph is normal. However, there is some edema on MRI compatible, let's say, with a mild grade of osteonecrosis. Whereas on the left side, you can see deformity, cortical collapse, the heterogeneous signal intensity on MRI, as well as the degenerative changes compatible with grade 4 avascular necrosis. In infants and young children, it usually involves the diaphysis of small tubular bones in hands and feet, hence the name hand-foot syndrome or sickle cell dactylitis. And that usually occurs due to the presence and persistence of the red bone marrow. It usually affects the pediatric population between 6 months to 2 years, and it rarely occurs beyond the age of 6 years. As you can see in this case, you see on the radiograph on the right side, the periosteal reaction involving multiple metatarsal bone. And the end stage, which is infarction and deformity and reabsorption of the bone. We have to be vigilant in pediatric cases because they can result in growth disturbance and deformity, as they will result in premature closure of the growth plates. As you can see, the slant deformity in the ankle and the cupping of the metaphysis within the wrist. Now, the second manifestation of vaso-occlusive crisis is subperiosteal hemorrhage. For example, let's have a look at this case. You see this arbonormal signal intensity within the left mandibular ramus, high signal intensity on T2, high signal intensity on T1. Of course, we have to pay attention to the clinical history, but again, this appearance could be seen in infection, could be seen in subperiosteal hemorrhage, and could also be seen in infarction. So whenever you are in doubt, always try to utilize your sequences. And in this instance, we used the gradient, as you can see, the susceptibility artifact reflecting blood. And so the diagnosis was of infarction with superimposed subperiosteal hemorrhage. This is another case of our archive, and this patient presented with a vaso-occlusive crisis. Again, you can see on the left side, the altered signal intensity involving the left iliac bone. And along that, you see a subperiosteal collection, heterogeneous on T1 and on T2, intermediate on T2, heterogeneously enhancing. And when we were thinking, we were in doubt whether it was infection or it was a hemorrhage, we did the gradient sequence. And again, you can nicely see the susceptibility artifact, which was subperiosteal collection. Hemorrhage. Again, one of the other manifestations of sickle cell is the anemia. And the anemia basically will result in overburdening of the bones. How do we see that on radiographs? We will see expansion of the diploic spaces, especially within the skull, and thinning of the inner and outer cortical bone. On lateral radiographs, we can see the heron end appearance. And again, we have to be vigilant not to confuse this for a sinister pathology. So this is basically just a reaction to increase bone production, RBC production. Again, because the bone is replaced by fibrosis, there will be osteopenia, that can result in some instances in pathological fractures. And since the bones are working at maximum efficiency, now the hematopoiesis will start taking place outside the skeleton. Basically, mainly it involves the liver and the spleen, and in some instances, we have the paravertebral or paraspinal location. And we again have to bear that in mind, not to confuse it with lesions. For example, this case, this was initially thought of as an adrenal lesion. Again, it can involve bizarre places such as the sinuses as well. Now, tackling the elephant in the room, which is infectious and osteomyelitis. We wonder, why are these patients more likely to have superimposed infection? First of all, there are multiple theories. The first one would state it could be because of hyposplenism. We spoke earlier that when we have multiple infection to the spleen, it will shrink. So we have hyposplenism, and that in return will result in impaired phagocytosis. Second theory would say infarction, especially within the bone, will result in subsequent fibrosis, which will create an excellent environment for bacterial overgrowth. Third theory, I'm not sure how accurate it is, but it states that multiple hospital admissions might increase the patient's exposure to certain bacterial pathogens. Now, what types of pathogens are we usually dealing with? Most of the cases, there's salmonella. Second of all, we have staphylococcus, which is usually found in 10% of cases, and that was found in our case. Gram-negative organisms, and in some instances, TB. You might be surprised. Why salmonella? Because one of the modes of transmission is hematogenous spread. So basically what happens when these RBCs sickle within the mesenteric vessels, they will result in gastrointestinal infarction, and then they will seep into the circulation and get into the bone. Or it can just be a direct spread from a leg ulcer, as you can see, or it could just transmit from the common skin pathogen like the Staph aureus and the anaerobic organism. They usually affect long bones as well as the vertebra. Usually the patients present with pain, fever, swelling, and increased inflammatory markers. However, bear in mind that these findings can also be found in the other manifestations of sickle cell disease, which we talked about earlier. Why is it important to start the treatment and first of all, diagnose early to avoid septicemia and bone destruction, and to avoid unnecessary long-term antibiotic treatment and antibiotic resistance? How do we diagnose these manifestations? Our radiological tools, of course, other than the physical examination, history, and the inflammatory markers, these are our tools in radiology: X-rays, ultrasound, CT, MR, and nuclear medicine. Now, I know that X-ray might not be that accurate, and especially in early stage of the disease. Usually in pediatrics, it takes around 5 to 7 days to have any manifestation on the X-ray, and in adults, 10 to 14 days. Well, there's simple things that we might be able to find. So first of all, we have periosteal reactions, which will tell you that there is an elevation of the periosteum, maybe because of hemorrhage, maybe because of an infection. So a food for thought. Also, you can see in these images, we have the periosteal reactions, and both of these are for chronic osteomyelitis in sickle cell patients. Or you might be able to see some lucency within the metaphysis. And again, in the correct clinical setting, it will direct you to think of an intraosseous abscess. Of course, we will confirm this on subsequent imaging. Ultrasound is a very useful tool, not because it's cheap and easily accessible, but also because it lacks ionizing radiation, especially in cases of pediatrics. It will enable you to see, especially in pediatric, subperiosteal collections, soft tissue collections, and in case you decided to go for an aspiration, here you go, voila. CT scan, again, as we know, the amazing properties to evaluate the bones. This is a case of acute osteomyelitis. You see the moth-eaten appearance of the lingual plate, then you see the erosions and the periosteal reaction. MR, which is the gold standards, in cases of infection. Your friends are your T1 and T2 sequences. You basically are looking for edema of the bone that will enhance on post-contrast images. So as you can see here, there's a heterogeneous enhancement, and this is a collection seen nearby. And again, as we have said earlier, whenever you're in doubt whether this is a hematoma in cases of subperiosteal hematoma or subperiosteal collections, we can always do a gradient. Osteomyelitis might be complicated by septic arthritis, or it can just occur by itself. What's the hallmark of this disease is fluid within the joint that enhances after gadolinium, and edema found on both sides of the bone, on the acetabulum and the femur, as in this instance. Bear in mind that patients of sickle cell disease, because of the infarction, they can have reactive effusion. So in these instances, it might be useful to do image-guided aspiration to alleviate any doubt. This is another case of our archives. It's for a 37-year-old female. She presented with a right side pain. On the T1, you can see widening of the SI joint with some cortical irregularity. You can also notice some joint effusion in the right SI that's basically seeping along the subiliacus, forming a collection at this side. You can also notice the edema within the bone as well. So unfortunately, I couldn't get post-contrast. That was an old case, but the diagnosis was of osteomyelitis with right-sided SI joint septic arthritis. Nuclear medicine can be helpful as well. We can do the technetium MDP. However, it could be in some cases confusing. Why? Because the for the technetium MDP, there is a high uptake on all three phases of the bone scan. But the infarction, although it's not as the same intensity, can have a high uptake as well. Therefore, when you're in doubt, you can do leukocyte imaging, which basically show the area of infection with a high uptake, whereas the area of infarction will be photopenic. So a teaching point, we definitely need the clinical history and an overview of inflammatory markers for these cases. In cases of, once we establish that this is an acute entity, we need to confirm that there is an acute osteomyelitis. So edema is the key factor, and contrast enhancement. Again, whenever we're in doubt, we can do gradient to exclude hemorrhage. When you're also in doubt, we can do a close follow-up scan. Nuclear medicine can be useful in some instances, and aspiration can also be helpful in some doubtful cases. So take-home messages, a message: diagnosing sickle cell is complex, is never too easy, especially you're dealing with not a clear bony background. You need to understand the musculoskeletal manifestation of this disease. Again, I emphasize on the history and the clinical picture. We need to learn our tools, know when to use them, and use our cool gadgets, whether they were in the form of gradient or image-guided aspiration. And again, short-term follow-up can also be useful in some instances. Thank you very much.
Thank you, Rola. There was a question here from Dr. Tatiana Gorbachova. Great cases and presentations. Thank you. Question for Dr. Vanderberg and Dr. Hussein. Regarding sickle cell patients, in your experience, can you have periosteal reaction in long bones, typically distal femur corresponding to the areas of intramedullary osteonecrosis as a manifestation of necrosis, or does it make you concerned for infection?
Yes, actually, it is correct. So when you see periosteal reaction, especially in a long bone, yes, you think, now again, as we said, now let's say that we took infection out of the picture once the history doesn't really go with it. But what I wanted to say that in cases of infarction, you start having a periosteal reaction, and then as it ages, this periosteal reaction will be incorporated into the parent bone. So yes, osteonecrosis acutely can present as periosteal reaction, both seen in the literature and in our practice as well.
Rola, could you please stop sharing?
Oh, sorry.
Yes, thank you. Bruno, your turn.
Okay, I have a question for Bruno.
Hillary, it's just that Tatiana wanted to know his opinion too on the same question.
Oh, I didn't see that. Okay.
Well, I have little experience with these acute infarcts in children, but in my little practice, yes, I would agree with Rola. You can have subtle bone reaction, periosteal bone reaction, but it depends on to look at. If you look at ultrasound, which gives you a very early idea of what's going there. In my experience, if ultrasound shows fluid in the subperiosteal area, then it's really suggestive of an infection. The periosteal reaction in infarct seems to be very, very limited and subtle, if any. So, I mean, if you are dealing with a young patient and in early cases, then ultrasound is probably the best way to go on if you don't have MR in a very rapid way. But it is difficult. Anyway, it is difficult, and I'm afraid it's always been difficult to make that differential diagnosis. It's red marrow. It's not white marrow. It's not yellow marrow. It's red marrow. It behaves in a different way.
Can I ask a question?
Yeah.
Lini? Dr. Vandenberg, I live in what started out as the endemic zone for Lyme disease, but it's really across the United States and into Canada. But 3 out of 4 of my family members have had Lyme disease, and we were all, readily treated when the typical rash came up, and never had arthritis, thankfully. But is there a way to know that if you are dealing with a rare instance where the antibiotics are ineffective, to avoid the septic arthritis? I mean, this was upsetting.
What do you mean? I just don't understand the question. What is the...
Is there a way? You said that there's rare antibiotic resistance in Lyme disease, right?
Yeah,
everyone is treated with doxycycline very, very commonly. And it, as far as I knew, it was always effective. I didn't realize that there was this resistance. Is there a way to recognize this? Is there a growing incidence of resistance?
No. We have to be, I mean, it's different. What we all have, and I did it have myself, the erythema migrans on the skin. And then you take the doxycycline and you are healed. That's the most frequent, history. Really, you will have arthritis or a CNS disorder. This is an advanced disease. And among these patients with arthritis, you will have 20% of these who will develop antibiotic refractory arthritis. So this is rare. I mean, arthritis is not common. It's not rare. It depends on your environment. And then among these patients, only a few of these will develop that different disease. And what is fascinating is the link between a septic condition and an inflammatory aseptic condition. And this is a very, very interesting topic for immunologists. By the way, in the recent literature, because I just checked a little bit of that, they say that there are genetic predisposition to develop this refractory form of disease. So it's a connection between our gene, the infection, and itself the infection can have various forms. It's very complex. So it's a very narrow area where you can develop these refractory inflammatory disorders. But it's very confusing for the rheumatologist or the clinician to shift from antibiotics to an immune treatment. You just hesitate quite a lot for a while.
Okay, there's another question here from Dr. Kai Herman. It's he asks, is it septic arthritis and Lyme disease in the sense that you can isolate the germ by puncture? Or is it a kind of arthritic reaction of the joint to the inflammatory process taking place somewhere else in the body, similar to reactive arthritis?
It's very rare to have the germs. In less than 5% of the case, you will have it in the fluid. So it's really a sort of immune-mediated reaction of the synovial tissue, and even the PCR can be negative. So it's very complex. And It's exactly the same with crystal arthritis. We all think, okay, if we have a crystal in the joint or if we have a germ in the joint, we will have arthritis. This is totally wrong. We need a reaction with our immune system. So if you have a crystal, it needs to be embedded within some proteins. Then you need to have the cells that will react, but not all of us do have these cells ready at that moment. So although we think these arthritis are a simple process, this is probably completely wrong, and we need several conditions to develop arthritis, whether it's crystal associated or even bacterially associated. We all have septicemia every day, but we don't get sick. So we need many other elements to become sick or get a disease. So it's not as simple as it seems to be.
Thank you.
No germs.
Okay. Thank you all for tuning in today. We all look forward to the next session, which will be held on April 14, with focus on intervention. Thank you. Bye-bye.
Bye-bye.
Thank you.